Okay, so we've gone over how to design these things, and we'll go over more about the design later, but I want to focus a little bit about the why and where we're planning these. So I want to start off by preaching to the choir and talking about the zero bone loss concept. Some have heard about it, some have not. Implant courses and implant surgeons, it's a very simple concept, but a lot of people either choose to ignore it or are not aware about it. So I want to go through depth of placement, tissue thickness, basically fixture choice, and the blend of all of those factors together is what a lot of people like to call the zero bone loss concept. And you hear a lot of people talking about, hey, you know, I'm not going to use guided. Hey, I can freehand parallel. I had no problems freehanding. They're posting pictures about their implants being, you know, side by side, looking like towers. They're proud of the fact that they can place parallel. They don't focus about depth, and the reason why people think that they don't need guided surgery is because a lot of the time, I'm not saying every time, but a lot of the time they're not aware about the zero bone loss concept about things. So I included this one picture from a recent case. The zero bone loss concept can be boiled down to two very important factors. One is the angle. Your implant that's in the bone, that's your fixture, and your restoration has contact points. The major reason why we place deep is to get this fixture point in the bone to be at less than a 40-degree angle away from the restoration point. Now, why is it a 40-degree angle? So we have this fixture here, and this is our contact point. This is less than 40 degrees. So right now, the hot thing in implant dentistry, it's moving away from using really wide fixtures with really wide platforms and more so towards narrower platforms, deeper placement, avoiding large GBRs, avoiding sinus lifts. So a lot of the times, you know, even the implant system we use, it has one platform for everything. And it doesn't matter how wide you go with the implant, the platform still stays the same. So the concept about the depth of placement stays constant. So for example, to get our contact point, in this case, to be less than 40 degrees from the fixture, that angle, we need a certain depth, no matter how wide we go with the implant. Now, another thing to consider is the tissue. So not only is one of the key factors the angle between the fixture and the contact, also some people say if you have from the crest of your gingiva to the platform of your implant 4 millimeters from the keratinized tissue to where you're inserting your abutment, you're usually deep enough. Now, that's not always the case. How many times have you guys seen cases where you flap open the tissue, they have like 5 millimeters of keratinized tissue and a knife edge ridge? So that's not always the best kind of indicator of how deep you should go. So yeah, often overlooked dimension, there's less grafting behind it. Old school dentistry, now I didn't practice in old school dentistry, but I know about it. We started off with external hexes, now it's internal hexes. External hexes, it's easy to restore, and a lot of surgeons back in the day, they say we can use a lot of insertion torque, we're not worried about fixture fracturing, we can go nice and wide, and basically the bottom portion of the implant very closely resembles the root that we're replacing. Hey, we got a big molar, we're going to place a big implant, we're going to have a nice emergence because our platform is nice and wide and we go directly from the platform to the contact. So that is an argument, people can do this, and that does prevent deeper placement, but our concept here is using a conical system that is one platform for any diameter of implant. So we need to go deeper to compensate for having a smaller fixture to restoration angle. So let's go next slide. All right, so here's a case, and we can see how depth of placement is very friendly to the tissue. So that's exactly the case we had pictured before. I overlaid some angles on it. This is how we restored it. We can see some concepts we covered today, like the immediately printed temporaries. I'll go through how to scan for these cases, how to capture the tissue that you made, but this perfectly kind of visualizes this graphic that I really like. I like to base all my placements on this graphic that's made by Dr. Francis and Dr. Noor. Everyone should follow them on Instagram. They're really good surgeons. They have a lot of educational content. So these zones of tissue, it really kind of displays how the implant needs adequate support from the bone, and then the bone has to adequately support the tissue around the abutment for our restorations to be nice and healthy. And the fact of the matter is, the zero bone loss concept is if your restoration and your abutment is not healthy, most likely that's due to a poor emergence profile. If your emergence profile is poor, that means the angles are off, it's causing a food trap, it's not cleanly. The cleanliness is not followed, basically. So that's the whole point about, Dr. Ross was talking about this earlier, the S shape. So the S shape is formed because, like we said, narrow fixture, and we have to build up a crown that gradually transforms from this narrow fixture up to this large tooth that we're replacing. Because for this premolar here, we're not placing a 6 millimeter diameter implant most times. And 100% of the time when you're using a conical system, if you're placing a 6 millimeter diameter implant, you're not gonna have a platform that's 6 millimeters. It's gonna be 3.5, 3 millimeters, whatever system you choose. And one other thing to mention about systems, I know I covered it last lecture, so I know a lot of people choose different systems for whatever reason. One thing that makes the zero bone loss concept work really well subcrestal is a conical system. So a lot of systems these days, screw retained systems like Implant Direct, like I would say Zimmer, I think is another one, BioHorizon. They're just a pure internal hex system, and that leads to one issue that's very prevalent in losing bone around the collar. So these systems, they only rely on the hex, and they have no conical portion above the hex to lock your abutment in place. So what happens in that scenario is that you're going to be using this abutment, the patient's going to be using it, it has a crown on it, they're biting into the crown, there's micro movements between the hex and the fixture, which is your implant body, and this causes bacterial infiltration, and bone doesn't like that. So once again, we circle back into cleanliness. So that bacterial infiltration basically is what makes the platform switch connection fail over time. Conical connection is kind of like a Morse taper fit. It's not only using the hex, which is mostly for timing, which I'll cover later, but it also pretty much cold welds the abutment and the implant together because it's a titanium on titanium contact. When you tighten it together, the walls of the abutment kind of squeeze onto the walls, the surrounding walls of the internal conical connection to the implant, and it forms, I wouldn't say a perfect bacterial seal, but it's pretty close to that. Now, we're going to be placing deep with the system we choose, and we have to manage certain indications when we place deep. One of those things is the crestal bone. So, like I said before, most platform switching implant systems, which a lot of the time, 90% of them have a conical aspect behind them for that bacterial seal. We're going to be placing it subcrestal. And depending on how subcrestal we go, sometimes the benefit of keeping that bone nice and healthy and the restoration nice and healthy is that we have difficulty restoring the case, or we have difficulty inserting parts for the future restoration. So you'll have, a 3.5 millimeter osteotomy, and you're 3 millimeters under the bone, and you try to put a healing abutment on, it's not going to seat. Or you're trying to put a scan abutment on, it doesn't seat. How do we do that? When do we do that? So that's what I want to kind of discuss right now. So here's a perfect example of that. We have an implant that's a little bit in bone. I actually got these graphics from the Blue Sky website. I like them, I don't love them, but it's a nice visual about how you can run into some of these issues. So that's a stock healing abutment. You can use stock healing abutments all you want. We'll teach you guys how to design your own. We call them anatomic profile generators, and we will link the file also at the end of the course. So here is the impingement. So right over here, it's not seating because this area of the bone, it's not profiled. So what do? There's two options. So one option is we can use a round burr and really carefully profile the bone using the manual method at time of placement. You can visualize where your platform is and then basically just round out the bone on all sides of it. Now, it's pretty sweaty. You're going to be worried about touching your fixture head. You don't want to be burning implants. So the way we like to do it is, once again, we have a kit. It's made by Blue Sky. There's also other kits for other companies. You are free to use the kits all you want. It's the same concept for all of them. Also, this can happen during uncovery. This happens all the time. Your implant platform is buried under bone because you actually grew bone over the top of it during healing. Now, what do we do for this scenario? Part of the profile kit, it involves this peg. The peg is like a healing abutment, but it's narrow. The peg is, do you remember what diameter it is?
On that?
Yeah, on the pegs, like three millimeters, I think.
Yeah,
It's always going to be less than the most narrow implant in the system. So you know for a fact, no matter what osteotomy you do, it's going to seat. You finger tighten it down into the body of the implant during placement or during restoration, depending when you have issues with seating. To save yourself the headache, I would do this at time of placement, because you're already performing surgery that day. They're nice and numb. You're already working in their mouth. They're sedated. All the good factors come into play. Now, here's a visual of the bone profile kit. So you have these latch, pretty much end cutting cylinders. And the concept behind this is that your modified skinny healing abutment, which we call the peg, is screwed into the implant body. And this end cutting cylinder perfectly fits over the top of it. So you put it on a slow speed or your implant motor, you hub it out until it can't go any deeper, and then you check your emergence after that. For, I would say 90% of cases, we use the largest one, because that one, if you're guiding your implants and you are the 40 degree rule and 4 millimeters away from tissue, most of the time the largest one of these is the perfect size for profiling your bone. So that shows you the speed that what you use it at is 800 RPM, and that's when it's hubbed out, pretty much. When it reaches the bottom, you'll never damage your implant, you'll just shape the bone around it. This is why I don't like the image from Blue Sky. As you can see, they completely disregarded the zero bone loss concept. Can everyone see an S-curve there? Because I can't. And they're choking that bone. There's no room for tissue. If you restore an implant like that, that's the old school method a lot of docs choose. And after 3 months, your bone level is going to be down here. Because guess what? This tissue here is going to want to attach somewhere. And this right here is a food trap, and it's just not a good choice of image.